It's great to see everybody here again today, and we're super excited to be presenting the results of the latest survey that we did, which is on prescription delays, denials, and non-medical switching. And then later on in this event, we're going to talk about what we're going to do with this survey and the other surveys that we have done in last year. But to start off, I just want to welcome the other two presenters who are here with me. So we have Lindsay Videnieks, who's the Executive Director of the Headache and Migraine Policy Forum, Carissa Charles, who is the Deputy Executive Director of the Headache and Migraine Policy Forum, and then myself, I'm the Executive Director of Migraine Meanderings. Before we do a quick introduction about our two organizations, I just want to remind you that this event is being recorded. And over to you, Lindsay.
Thank you, Shoshana. And thanks to everyone joining today as folks hopefully are winding down for the year. I know everyone's excited for 2024, but this is the home stretch. So for those unfamiliar, the Headache and Migraine Policy Forum is a 501c4 organization that functions as a coalition of, I think, 24 stakeholder groups that are really policy-minded. And so we seek to educate policymakers and advance public policies to improve access to treatment. A lot of the topics that we've talked recently about with regard to utilization management. So just happy to be partnering with Migraine Meanderings here.
Thank you, Lindsay. And of course, Migraine Meanderings is a DBA of Hope and Pain, Inc., which is a 501c3 nonprofit organization. And the mission of our organization is to provide patient-oriented resources, encouragement, support, and education for people who live with migraine, to raise public awareness about this disease and to empower patient voices. And it is that last part that is so important as we do these surveys. So we're going to start off with demographics. So in this particular survey, we had 498 people who completed the entire survey. It ran from October 1 to November 6 in 2023. And this is just a real quick overview of the demographics, which are very similar to our other surveys as well. In terms of headache frequency, you have 59% of people who answered the survey have chronic migraines, somewhere between 15 to 30 headache days per month. But what is really good this time, and with some of the other surveys, is that we're seeing that we have about 41% of people who have episodic migraine, and 17% of those have low frequency episodic. In terms of health insurance coverage, you'll see those numbers don't add up to 100%. And that's because some people who completed the survey have both commercial insurance and either Medicare or Medicaid, or both Medicare and Medicaid as well. In terms of gender, no surprise here, 91% of people are female, but 8% are male, 1% is other. The good thing about that is we're starting to see those numbers for men creep up so that they can be more represented in our surveys and in the other events and awareness products that we produce as well. Then in terms of age, again, no great surprise here. Our biggest reach there is going to be between 41 to 55, that's 43%. But it's interesting that we do have 24% of 26 to 40-year-olds and 5% of 18 to 25. And again, we're starting to see our reach kind of creep out a little bit of the traditional older person who tends to answer these surveys. And I think interestingly for me is we have 28% of people who are 56 plus. And those are the people who are often caught out when new medications come on the market. They often can find themselves caught in the donut hole for Medicare. And often exclude different clinical trials as well. And so they may experience more side effects from medications, adverse events, they have more comorbidities. But we do see that over a quarter of the people who answered the survey fit into that age bracket. I'm going to hand over to Lindsay for these pages.
Thank you, Shoshana. So just to level set for those unfamiliar with what we call utilization management language, which is sort of just a fancier way of saying, you know, the hurdles and hoops that patients might have to navigate in order to receive access to a therapy that their provider has prescribed to them. So, you know, prior authorization is sort of this check run by insurance companies where they, you know, require, based on maybe age, medical necessity, or available of a generic, for example, sort of pre-approval, if you will, for the therapy. So that may require folks going through step therapy or other sort of fail first. And so it's a barrier for patients because it's one more sort of burdensome measure that they'd have to go through. And then non-medical switching, you know, for those unfamiliar, that is just sort of a mechanism that health insurers use as a strategy to control costs. But in this case, it forces, you know, stable patients to maybe switch from a current and effective medication to a drug that may not be working for them. And so particularly for this community where, you know, you wake up on any given day and not know what that day will bring in terms of your health, having that instability and being non-medically switched is a real problem. So that's all to say that for this survey, 64, well over half of respondents reported these two types of insurance barriers associated with, well, for prior authorization, first of all, and then also non-medical switching alone was 3%, but a full 33%, 1/3 experienced both non-medical switching and prior authorization. Next step, or next slide. So what's the real world outcome of that? In this case, for our respondents, I think we had close to 500, Shoshana, right? It was 42% of those respondents report having to wait more than a week for their insurance provider to approve their prescribed treatment, and 10% never, ever received it. Now, because of the good work of a lot of groups that are on the webinar today, there's sometimes state legislation that says to an insurance provider, you have X amount of time to make that decision, to not keep patients sort of waiting. That may be 48 hours, it may be close to a week. But in this case, you saw even where those measures are in place in some states, 42% of respondents still experience this. So, you know, and actually 16% was, you know, experienced PA delays of a week, 25% of a few days, but less than a week, and only 16% were less than 1 day. So I think that it's alarming to see that a full 10% of migraine patients just simply never received access to their therapy. Next slide. I think I'm turning that over to you, Shoshana.
Yes. Yeah, and the only thing I would add to that is that often patients don't know what to do when a medication is denied. When they get to the pharmacy, they don't know that it's a prior authorization. Most patients don't even know what a prior authorization is, let alone all the other terms that we use in these surveys. And that's where a lot of education needs to happen. But also, I would say that most patients presume that their doctors or the doctor's offices are just going to resolve it. And that often doesn't happen in the way that it should happen. So here we're looking at patient experience with prior authorization. We know, obviously, insurance delays and denials will negatively impact how patients feel. 86% of the people who completed the survey said that it made them stressed and anxious. 67% said it made them angry. 44% hopeless. 63% that they were exhausted and weary. 42% depressed, and 30% afraid. I think that's really important to know. You may wonder why people are saying that they're afraid, but the consequences of not being able to access their medications, of having uncontrollable migraine attacks, or possibly ending up in the emergency room again, or possibly losing their jobs or relationships, all that goes to build up for fear. And of course, all these things have consequences, not only for migraine, but also for any comorbid conditions that patients have. We know that the insurance delays and denials negatively impact patients' ability to sleep, which obviously is key because it has a direct correlation to migraine frequency and migraine severity, as well as other conditions. 61% their ability to work, 69% to manage family obligations, 67% be in social settings, 12% to go to school. So it's not only impacting their health because of lack of sleep, but the implications are on financial loss, broken families, and all the turmoil and financial impacts that come from that. Isolation, which we know has a severe impact on any kind of chronic disease. And then, of course, their ability to go to school result in people not being able to complete degrees, which impacts their ability to work and their financial ability going forwards, which has an impact on the insurance they're able to get as well, and the way that they're able to treat this disease. And so we can see it just goes down in a downward spiral. Insurance delays and denials negatively impact overall health. So 26% of the people who completed this survey said that because of those delays and denials, they had to go to the emergency room or the urgent care for treatment. 78% said that they had migraine attacks more frequently. 77% had more severe migraine attacks. 24% developed new or additional migraine symptoms. 39% made other health conditions worse as a result. And 6% saw no difference in migraine attacks at all, which is de minimis for that. It was only 6%. I think really interesting is that first one where it says 26% had to go to the emergency room or urgent care for treatment. And we did do another survey on this and the consequences of people with migraine having to go to the emergency room or urgent care for treatment. And I'm going to pass back over, I think, to Carissa.
Yes, and as Lindsay mentioned, non-medical switching is a practice in which insurance companies force patients with migraine on stable medication to change to an alternative, and this is mostly driven by cost considerations or agreements with other pharmaceutical companies. And the issue with this is that patient medications are usually changed to a chemically distinct alternative, and it expected to have a similar result. So as you can see, 46% of people reported that insurance stopped covering medication being taken, while 3% reported their health plan increased the copay medication taken, making it unaffordable, while 17% of respondents stated their insurance stopped covering the medical device being used. While 7% reported their health plan decided their copay card could be used to help pay for medication no longer applied to the annual deductible, while 39% both reported their insurance changed to a different treatment, as well as reported their prescription change, were unsure of how or who or how. Next slide, please. So as you can see, their insurance required treatments switched for non-medical reasons. So as you can see, 30% reported it was switched to a brand name triptan, 29% to injectable monoclonal antibody, and 3% reported it was an IV migraine treatment, 20% oral nasal spray CGRP inhibitor, 13% botulinum neurotoxin injections, while 5% ergotamine treatments, and 2% medical prescription medical devices. Next slide, please.
And if I could just add one point, Carissa, for those unfamiliar with how sort of the payer may interact with your provider's office in terms of the decision they're making for non-medical switching, these are peer-to-peer decisions, you could say, because there's an MD involved, but these are not necessarily headache specialists, certainly not, or neurologists making these decisions to non-medically switch. It's someone at the plan who is a doctor. But I think that maybe the worst example I had was it was an OBGYN or someone who was a cardiologist making decisions about migraine patients and whether they should be switched, just completely unfamiliar with the disease state and sort of the unique sort of toolbox approach that patients have to undertake. And so it's frustrating because, especially with non-medical switching, you have a lot of these decisions being made by providers who are not specialists and who don't understand the disease. And they may not understand, sort of the outcome of that decision. Sorry, not to interrupt.
Thank you. Next slide. And yes, so for non-medical switching, it's also can be troublesome for patients because if patients have tried several medications over the years and finally found the one that works best for them, it can lead to issues down the road and just sudden change in medication. For example, as you can see, 28% reported that they were switched to a triptan, which is an abortive treatment, while 19% reported it was an anti-epileptic medication, 20% tricyclic antidepressant, and 19% beta blockers as well. And I believe I'm passing it over to Lindsay.
Yeah, so again, this mirrors a lot of what Shoshana showed on the PA side, right? So that impact on sleep and corresponding to work, how much of these things are interconnected, right? Many of them. So you don't get adequate sleep, you're probably not going to perform as well at work or be able to get up with your, 3-year-old or be there for those family obligations. Probably don't have a lesser desire to be in social settings because of how you're feeling. And then again, that impact in going to school. So, the cascading effects of all of this, we have had a separate presentation on the resulting, expense and burden of having to go to the ER when a lot of these switches occur or utilization management or burdens impact patients, and there's a financial cost to all of this. So this very similar to the PA slide that we saw. Next slide. So, again, to that point, for a full 14% ended up actually having to go to the ER or urgent care for treatment. 50% had migraine attacks more frequently, and we know this is a progressive disease. 49% had more severe migraine attacks. We know every attack is different. And then 20% developed new or additional migraine symptoms, while 32% made some of the other comorbid health conditions worse as a result. That could be anxiety, it could be depression, many that are comorbid with migraine. Only 6% really said they saw no difference in migraine attacks. So the story here is, that full 94% of folks really did have some sort of impact on varying levels. Next slide. Additional findings. I think that Shoshana, are you taking this one? Or I can.
Yeah, I can jump in on this one. That's fine. So this is just some additional information we got. 22% had been taking the prescribed treatment for 2+ years at the time they were switched for non-medical reasons. And that's very important to know. This is not just non-medical switching because a doctor prescribed a new medication and the insurance decided to switch it to something different very early on. But these patients are often stable on the medication that they're using, and then they are switched. 50% of the respondents to this survey said that non-medical switching was a significant disruption. 52% say that losing access to the treatment that worked for them has impacted their ability to manage their migraine. 49% say losing access to the treatment that worked for them has negatively impacted their mental and emotional well-being. And I just want to speak into that a little bit, and we can put a link in the chat once we go to Q&A. And that is that we know that there is a direct correlation, obviously, between depression and migraine. It goes both ways. But we also know that for people who live with migraine, they're at higher risk for suicide attempts and for suicidal ideation. So overall, using the statistics guide from CHAMP, we know that 15.5% of people with migraine experience suicidal ideation. 4% have attempted suicide. And when you put that into the numbers of 40 million people, just in the US alone, that's 1.6 million people attempt suicide. That is a shocking number, but it gets worse because we know that for people with chronic migraine, those numbers are radically different. And the Association of Migraine Disorders did a wonderful article about that has links to all the different studies on this topic. We know that 47.2% of people with chronic migraine experience suicidal ideation. In rough terms, that means half. So you have 2 people with chronic migraine, at least one of them is likely to experience suicidal ideation. 13.9% attempted suicide. That's just such an incredibly high number that I think that it's shocking. And when we talk about migraine not having, a morbidity rate attached to it, we need to take this into account as well, and all the implications of the utilization management issues. So I'm going to move on quickly to patient feedback before I hand it back over to Lindsay. This is just some of the comments we give people when they do these surveys, the opportunity to write comments and to add anything. So this is just individual quotes from people. Insurance companies should not have more power over my health decisions than my doctor or I do. Treatment delays cause future treatment to be less effective. And that is especially true if the disease chronifies because of what is going on. I ended up admitting myself for inpatient mental health care because my depression from fighting insurance compounded other conditions, and I knew I needed help. And that speaks directly to the suicide attempts and suicidal ideation numbers that I just quoted. It is cruel to put profits over people's well-being and cause needless suffering. Someone else says it took months of fighting my insurance just to get one medication approved. I don't think I could go through the mental anguish again because I don't ever want to get back to the mental space I was in when I had to fight for one medication. And I can speak to that directly for myself. It is exhausting. I've had to fight for just about every single medication that I have. And when you get approved, it's often only for a 12-month period. And then if your insurance changes, you start from scratch all over again. And we get burnt out in trying to deal with insurance. Sometimes I will spend hours and hours every single week, sometimes hours in a day, just bouncing backwards and forwards and trying to get straight answers and trying to reach someone who can make a change. And I didn't write that particular quote, but I totally relate to it and relate to this other one as well. I have lots of anger. Why does insurance decide what is best for me? Why does insurance decide what is best for me? I'm going to pass it back over to you, Lindsay.
Thank you, Shoshana. It really, it speaks to the emotional bandwidth. I'll just say demographically, and we saw this in the survey results, you also have women who are what I guess would consider child, the sandwich generation. They may be caretaking elder parents. They may be caretaking children. It's exhausting to think about. And we know women oftentimes put themselves last with regard to their healthcare, having to fight a large insurance company just to get access to care and treatment so you can have a quality of life to help support everyone else around you. So before we have a couple questions that were put in the chat box that I want to cover, but I want to make sure folks know that, number one, this is the final survey in a series, I think, of 4 that Shoshana and I undertook with her Facebook group a year ago through this year. We did a similar survey on ER usage, on device access, and then also on step therapy. So please go check those out on our websites and YouTube channels for that content. We might share the links to all of those as a follow-up. But the idea that, this is sort of a capstone survey to that project. Now that we have this survey completed on prior auth and non-medical switching, we intend to package all of the findings into one larger report that basically is a finger on the pulse or a snapshot of lived real world experience for migraine patients. And, it's wonderful that we have so much engagement on this webinar. We also want to make sure that we are sharing this information with people who can do something about these problems. So that package report will be cut up into nice little infographics and shared widely on social media, but it will also be mailed directly to every health insurance commissioner in the country, as well as shared with the National Council on State Legislators and external coalition partners. So HMPF, some of our members join, for example, the Safe Step Coalition. This is a group that's working to reform some of these issues on a federal level. So once, thanks to the Supremacy Clause, if we can fix it up in Washington, then on the state level, it's not such a whack-a-mole approach. But these are external partners in totally different disease states who are taking a leadership role in helping to reform some of these utilization management tactics. So we'll share this information with them because this is great ammunition for them as they're meeting with lawmakers and other folks who can make change. And so we know that PBM, pharmacy benefit managers who are responsible for a lot of utilization management. There is a federal bill that is moving to reform some of these measures, hopefully again next year through the end of this Congress. And so all of this information and participation will be shared with those folks so that they can utilize it with whomever they're speaking to. So please know that this information doesn't just live on a webinar in a vacuum. It will get arms and legs and reach the right audiences. So I think we have, okay, Shoshana just shared the Association of Migraine Disorders article on suicide and migraine. So thank you for that. I might just, Shoshana, do you want me to sort of reflect back the 2 answered questions in the chat box for the audience?
Absolutely. Yeah, I think that would be great.
Yeah. So I guess back when I was covering prior auth, and I think there was a question about the time range for the survey respondents for PA approval. Was it just the period of time between submitting the prior auth and then the ultimate approval? Or did it also count time delays by the healthcare provider offices? I understand it to be the former. So it was the time by which someone was prescribed and then they ultimately received approval and access to therapy. So, again, we'll share the survey results widely with this group after the call, but yes, that's the time period that we're talking about. And then Vera Gibb made a comment about, it could be OBGYNs, GIs, podiatrists, internal medicine providers providing peer-to-peer reviews and making these decisions about prior auths. That's a fact. That is a fact that you may have worked months and years to have a relationship with your headache specialist and been lucky enough to get an appointment. And moved a whole bunch of things around your day to make that appointment happen. And the person on the other line at the insurance company could be a podiatrist who has all respect to that profession, probably less of an understanding of the disease than a patient does. So making really critical decisions about access to therapy and whether or not a patient's going to go on this roller coaster journey of approval. And so it's depressing to think about, but at the same time, we try to stay positive and look forward to taking action on these issues. I would also ask, those are the two questions in the chat box. We might have another that came in.
We do. Let me just jump in on the first one, if that's okay.
Please.
Just to clarify and agree with Lindsay that is the time from when the therapy, the treatment is first prescribed to the patient. Again, just to reiterate, a lot of patients, not all, but a lot of patients, and probably most, do not know when the denial is taken care of by their doctor's office. It's a mystery, that period. All they know is that, for example, they go to the pharmacy and they discover that they can't fill the script and they know it's denied. And we see this every single day in my group. People are posting about this. I've been denied, that's it. Or I've been denied, what do I do? And they really don't know what to do. They don't know that the insurance has to provide a reason for the denial. Many don't know that in many cases you can call and you can talk to someone at in your insurance company. Patients don't know how to work together with their doctor's office to get things approved as well. And I think that's a large part of what we need to do here as well, is that while Lindsay and her team are going to be taking on the PBMs and the payers, migraine meandrine's part in that is going to be educating and empowering patients and giving them scripts and giving them a kit so that they know what to do when something is denied. And I think it's also, it would be unfair if we didn't note that this whole system is extremely burdensome for doctors and other healthcare professionals. So it's not just the patients it impacts, but it's the doctors as well. It's such a burdensome system.
I will tell you an interesting story that was not in the migraine space, but I heard that a cardiologist did, which is on one level, they were so frustrated. It was, I think, 99% denial for all of his patients for a certain therapy, that he got on the phone as a peer-to-peer talking to the doctor and the insurance company and said, what's your medical license number? I have to carry medical malpractice insurance. And if I can be sued for negligence, then you're part of the care team now. You're making decisions that impact my patient. So congratulations, we're working together. Give me your medical license number, because if I can be sued, you can be sued. Now, that's fairly aggressive. We love that doctor. But at the same time, I think it speaks to some of the frustration that James Charles wrote in about, the fact that so many of these life-changing, I can't say life, a lot of these decisions are being made by folks who are simply not the headache specialist. And so it is absolutely a challenge. I think I just asked Carissa to drop into the chat. We just recently released, I think, a pretty simplified one-pager on how to appeal a denial. And, it links to another resource we have on filing an insurance complaint. So if you are having sort of a systemic issue, and I know the Alliance for Headache Disorders Advocacy is also elevating this issue, you have the right to file the appeal, but then you also have a right to file a complaint with your state insurance commissioner, because if they can see that there's sort of a systemic problem with an insurance company, they will act as an intermediary and try to get a resolution on that. And so we encourage folks to check out that resource. It is empowering because it at least allows you to take action, not that anyone has any extra time to work on all of this. But if, as a patient, an individual patient, you don't know where to turn, I think getting resources through Shoshana's group, checking out a resource that we have shared, I think that's a great first start.
Right, absolutely. I was just going to add one real quick thing. Sorry, it's obviously such a hot topic, this is, and that is, when we're talking about, patients getting involved, patients appealing their insurance denials, the hours it can take just to appeal one. If you're still working full-time, or if you even work part-time, but outside the house, you just simply may not have the practical ability to do that. It's just impossible. And so that just adds another level of burden here. I'm going to take that, the first question we have there, Lindsay, the anonymous one. Do you have any results broken out by attack frequency? We do not have that right now, but we absolutely can easily do that from each of the surveys. Yes.
I think that folks can't see the chat. So I just dropped into the link of the answer Q&A where somebody said I can't see or use the chat unless there's a better way. I dropped in that resource that Carissa mentioned. So that's the link. If there's a better way to do that, Shoshana, let me know, but
Probably not.
okay.
People should be able to see chats. I'm not sure.
Okay.
I don't have the control over that. I don't think though.
Okay, now it's unlocked. There we go.
Perfect.
Okay, so I'll just redo that. Okay, it's everywhere. Okay.
We have an article here. Oh, I see Vera Gibb puts an article she wrote, how to get prior authorizations for migraine medications. Print it out, take it to your doctor. Absolutely. That's a really great article. And I think we should add that to our list of resources as well, Lindsay.
Thank you, Vera.
And it looks like the other ones all answered.
They are. Thank you, Rachel.
Totally agree, James Charles. Absolutely agree.
Yeah.
With your comment there. For those who can't see it, he wrote the insurance PBMs have been given license to maim and kill. Why can't there be intervention from lawmakers? Why are the PBMs allowed to prevent modern CGRP therapies to the front line when prescribed by headache specialists? There's a criminal element denying and taking away an effective therapy from a headache specialist. So true.
So, and on that level, I would just say that, you know, Congress is working on this issue. It may work at a glacial pace, but there is a bill that includes a lot of bills, many bills wrapped into it. The Safe Step Act being one of them is part of a PBM reform package. And so there have been a lot of hearings just during this Congress about sort of the abuses of pharmacy benefit managers and the folks who are sort of coming up with these utilization management tactics. And that's a whole nother webinar, but yes, the short answer is there are bills on the table. They have bipartisan support. You know, we're in divided government, so it's essential to have both sides of the aisle that agree on some of these things. And so my understanding is that as recently as December 8th, there's been talk about how, I guess in January, that's going to gear back up again. So this Congress, of course, will conclude at the end of the fiscal year, September 30th, 2024. So they have to get any legislation done by the end of September 30th, or else that sort of hits a reset and everything turns into a pumpkin and you have a brand new Congress that has to come in. You have to essentially start over and reintroduce bills. So I think there is momentum. We're going to an election year, but there's momentum for this legislation in particular because it has such widespread support. That's the positive. We have some additional questions.
I just answered the one on the suicide statistics.
I
just put that. It's in the chat as well, but I just put it into the Q&A.
Okay.
At least I tried to. Maybe that didn't go in.
Yeah.
Yeah, hopefully it did. There we go.
Awesome.
Okay, and then just I think to reiterate, you know, most of this work from here on is going to happen starting in January. So stay tuned. You will be hearing from HMPF and from Migraine Meanderings. We're going to be keeping you updated. If you want to watch this video, this webinar again, it will be on both the HMPF's and Migraine Meanderings YouTube sites as well. We also have a summary report of this latest survey that is going to be on our website. So we're trying to make all these resources as available as possible. But again, the next steps are predominantly going to happen beginning in January. And it's going to be really interesting. We need everybody's help. So anybody who can be involved, the better.
I want to know if anybody on the call has seen all 4 webinars. I'm not saying we're giving out prizes, but if you have, thank you.
Yes.
Because this has been a series and it's been a wonderful series. So we appreciate everyone's interest and support. And to Shoshana's point, we will keep you updated through these channels with, you know, any further activity. But thank you so much. We'll give folks back a little bit of their time. And Shoshana, Carissa, anything else you'd like to add?
From my end, that's it. Just thank you for staying with us. It's been over a year working through this whole series, and we're really excited to take it to the next step.
Yeah. Happy holidays, everyone.
Thank you for joining.
Yep.
Happy holidays, everybody.